Hi, I'm David Cohen, Chief Product and Technology Officer at Greenway Health. Virtual care has risen to the forefront as a key means for providers to treat patients outside of the four walls of their practice. As a key part of Greenway's vision for long-term virtual care success, Greenway Telehealth enables the remote delivery of care to improve patient outcomes. Visit greenwayhealth.com to learn more.
Hello everyone, my name is Chris Harrop, Senior Editorial Manager at MGMA. Welcome to today's session, Expanding Care Management Strategies Through At-Home Interventions. We have a few reminders before we begin. You can claim ACMPE, ACHE, CME, and CEU credit, and if you view the live session, AAPC, CPE, and CNE credit. Claim continuing education credits starting next week using the MGMA CEU portal. The code for AAPC credit will be emailed to you. Submit your questions, resources, and comments using the chat area. Slides and resources can be found in the lower left section of the previous session page. And with that, the education for this session will now begin. In today's session, Andrew Chang, ACO Executive Director for Aledade, Florida, and Dr. John Kappelman of Kappelman Medical Group will explore how an independent primary care group, as part of a Medicare ACO, found local partners to launch in-home weekly visits as part of a comprehensive care management strategy for high-risk, high-cost patients. Andrew and John, I know you've got a lot of great information to share, so I'll turn it over to you.
Thank you for joining our session today. We're going to talk about expanding care management through strategies through at-home interventions. I'm Andrew Chang with Aledade.
And I'm John Kappelman, an internist in Winter Garden, Florida.
To give you some learning objectives for today's session, we're going to discover how at-home care can strengthen a comprehensive team-based approach to care management. Also going to discuss the use of non-physician providers and how they're really beneficial to supplementing care management beyond the four walls of the practice being Dr. Kappelman's here. And we're also going to talk about how we produce potentially improved quality of care, utilization, and control cost results for the highest need patients at that practice. As I said, I'm Andrew with Aledade, and to give you some background, Aledade is a company that was founded in 2014, and our main mission is to sustain physician independence so that physicians like Dr. Kappelman can succeed in value-based care arrangements. We do this by setting up things like an accountable care organization through Medicare Shared Savings Program. We also help to manage value-based risk arrangements with commercial payers and so much more. We provide a population health management platform called the Aledade app and also provide other solutions so that practices and physicians like Dr. Kappelman's can succeed in value-based care and thrive in their independence.
And my medical group was started approximately 10 years ago. It actually was born of a eight provider group that I built up until about 10 years ago. And then I decided at that point that things were not going the way I wanted to do. I was spending so much of my time administering that practice and not taking care of my patients like I wanted to, that I actually blew the group up and left and began this independent single provider with one nurse practitioner group 10 years ago, again, with the purpose of being a personal physician to all my patients, and also establishing a state-of-the-art electronic medical record group.
And Dr. Kappelman, you joined us in 2016 when we stood up that ACO.
Yeah, the ACO is just a natural progression of what I was trying to do, and that occurred about at the 5-year point. It's been a wonderful opportunity to do what we enjoy doing it for the right reasons, and also get reimbursed for it.
Yeah, and that's really the beauty of what Aledade and partners like Dr. Kappelman, we are able to align our incentives and make sure that folks like Dr. Kappelman, with the work they're already doing, they're able to sustain their independence and get paid for it. So to move into our session today, we were both approached with the ACO and Kappelman Medical Group by a community partner. They essentially wanted to test a paramedicine program that would send a paramedic into the home in order to do a full 360 assessment of that patient, provide additional services, This was an opportunity that was grant funded by a not-for-profit organization in the district. And what we did was we aligned with that group in order to make sure that Kaplan Medical Group patients, as well as the patients identified by the Florida ACO that Aledade runs, that we were able to enhance the current care management program, but also hone in on those high cost and high utilizing patients. So that way we were really advancing touches that could not be met through typical rounds within the practice. We launched this partnership in the spring of 2019 and studied it through the spring of 2020. And what we'll review is the study of that pilot that was conducted within this service partnership.
I'd like to say a little bit about the West Orange Healthcare District, the entity that's funding this project with the Health Council paramedics. It's an entity that was born out of the purchase of a local hospital, and they've been doing their best to enhance the healthcare of the community that I practice in. And this was an opportunity that they came to us with, and we seized on it. And I just want to commend them for their foresight and their commitment to enhancing the healthcare of West Orange County, Florida.
So some of the services that this paramedic group was going to offer, you can see here on the left, things like home patient assessments, wellness visits, remote patient monitoring, palliative care. There really was a gamut of services that we could select from. What we ended up with was, through what we were already doing within the ACO measures in our partnership with Kaplan Medical Group, we decided to hone in on home patient assessments, hospital readmission avoidance. Later on, you'll understand why some blood, urine, and lab samples were done as well. Specialist updates, as you can imagine down here in Florida, we have a high density of specialist care, and so we wanted to make sure that we were giving touches pre and post specialists, as well as a custom request for follow-ups on those specialist visits. Within the services of that partnership pilot, you can see here the home assessments. Within all of these, once the paramedic completed their visit, there was an assessment that went back to Dr. Kaplan in the practice, so that way they understood what was going on. Within the home patient assessment, you can see here the entity of that evidence-based assessment included things like a medical history, making sure a med reconciliation was done. You can see vitals, LACE score, patient satisfaction was a big one in order to understand how they felt the visit had gone. Hospital readmission avoidance was a big one here as well. We wanted to make sure that evidence-based assessment included as well more weekly touches. They did about 2 visits per 30 days. And then we also looked at transitional visits out of the program. Now, Dr. Kaplan also is a wonderful physician by performing transitional care management on those patients. So they were already being seen for that and then enrolled in this program as well to make sure that they did not readmit. Additionally, there was follow-ups on the specialist visits. We would make sure that after they left the care of that specialist, they were included in that 2 weekly visit for 1 to 2 weeks. Again, reports were given over to Kaplan Medical Group. And then lastly, blood, urine, and lab samples were done. Once COVID hit in March of this year, we realized that there was an opportunity to continue the continuity of care for the Kaplan Medical Group. And we wanted to make sure that patients were not canceling necessary appointments because they were not able to have those labs and other draws done. And so we were actually arming them through supplies from Kaplan Medical Group in order to do those and send it back to the practice in order for the labs to be done. And then Dr. Kaplan was able to go about doing those visits either via telehealth or within the practice. Anything you would add there, Dr. Kaplan?
Yeah, the ability to have someone go to their house, and even initially they were just doing another telephone contact, but that second contact, that second point of contact that these people had already experienced, this was more of a continuation of previous services. It was a reinforcing aspect of our care, and the ability for these people to go in the patient's home during this time was just another way we could still provide care for them without actually bringing them into the office.
And one thing to highlight, there was care management already going on at the Kaplan Medical Group, and there are clear benefits to care management. we wanted to just make sure that what we were doing with this program is we were enhancing those services. And so as you can see, the benefits of care management on the left, things like reducing treatment costs, ensuring that adverse reactions to medications were being avoided. The benefit of this, as Dr. Kappelman said, is they were able to go in the home and do a full assessment of those patient surroundings that you typically would not have the ability to do unless the physician went to the home. And I don't think anyone has time for all of their patients to do that. You also were able to access their medications. And this is really important because I'm sure Dr. Kappelman can expound a little bit more on this, but patients will say that they're on these medications, they're adhering to them, but having someone physically go in, make sure that there's not old medications, potential for adverse reactions, and that they are actually taking them is a huge benefit.
Yes, seeing the patients in their environment and even how they organize their medicines, they can bring their medicines into the office, and it's still not the same as seeing how they organize them, how they put them out, how they store them. Not to mention the paramedics would also do a nutritional assessment. They looked at their refrigerators, they looked at their environment, and was there anything that needed to be changed or reinforced with another family member that would help further these patients' healthcare.
Yeah, and in one story that was shared with us, not within our study, but within the overarching paramedicine program, was the fact that they went in and realized that this patient was getting Meals on Wheels for their nutritional needs. They actually weren't eating those meals because their refrigerator was not functioning, and so those meals were going bad. And they ended up partnering with a local community organization to get a new refrigerator for that patient. So that way those meals would not perish and they can continue their nutritional diet as directed by their physician. So things like that continually were given back anecdotally around the qualitative side of this, which we'll get into in a little bit more detail in the future slides. But additional enhancements here, they were able to check in with the patient in their own environment, which really reduces the anxiety seen by some patients when they go into the office, such as white coat syndrome. We also were able to potentially utilize face-to-face telehealth with Dr. Kappelman if needed. And then if there was an intervention that was necessary, we could potentially avoid, say, them going to the emergency department and potentially getting admitted by having that one-to-one connection with the paramedic and Dr. Kappelman and saying, hey, this is what I'm seeing. This is what the patient's vitals are showing. What would you like me to do? And Dr. Kappelman was able to intervene and direct where that patient should go.
I should add, it wasn't just me, it was my staff. Everybody was on board with this. The paramedics knew they could call my nurse, my receptionist, my office manager, and we could discuss, even if I wasn't immediately available, these people were part of our team, and we could discuss at that moment whether the patient needed to go to the emergency room or, more importantly, could come to the office right away. And that happened more than 5 times during this trial, that we just worked somebody in rather than them going to the emergency room and potentially being admitted. The paramedics were very good at assessing how serious the patient was. And the other aspect was if the patient was not that serious, but their anxiety was through the roof. These people were very good at alleviating that and contacting us if we could help and alleviate that anxiety, because an anxiety attack will lead to an emergency room visit every time, especially with a chronically ill patient.
Yeah, that's a good one to know. And in terms of the design of the service, really it's a pretty simple workflow. So we would identify what patients, either by the practice or through our ACO analytics, which ones would benefit from this type of service. We would then volley those over to Dr. Kappelman, who would review those list of patients and write the referral into the service. Upon acceptance into that referral, the paramedic would receive as much information as we could give them and conduct an initial patient home assessment, as we stated in those previous slides, what that was entailing. That initial visit could take anywhere on average from about a half hour or longer, really depending upon the variety of factors that the patient is presenting with. A visit cadence at that time would be established, and typically it'd be about 2 times a week for about a month. We would determine whether or not graduation after that month was needed or whether future enrollment should continue. Upon all visits, that paramedic would relay the information back to Dr. Kappelman and designate any of the required follow-ups if needed. And at times, as Dr. Kappelman was saying, we would identify a patient in need of immediate care. And so that would trigger either a same day or next day appointment, pending what it was. And in extreme circumstances where the patient could not actually drive themselves into the practice, our ACO has partnered with a ride sharing program in order to transport those patients on their behalf. Anything you would add there in the design, Dr. Kappelman?
No, we were very much involved every step of the way. The paramedics communicated with us extremely well, and they had the authority to do what needed to be done in the moment. They're, again, part of the team. It worked out very well.
And one factor that I should note here is with the Healthy Orange District, there was a stipulation on making sure that those patients were within the district's zip codes. That did limit down the amount of patients that we were able to enroll to a degree, but we still had a fair number of patients enrolled in this. In talking about those referrals, as you can see here, this is the month-to-month thread between February of 2019 all the way out to March of this year. There were actually 29 patients in the initial analysis for the study. We actually had to pare it back down to 26. There were 3 that were disqualified due to either a lack of match to a peer group or not having proper length of enrollment, so ending early within the program. Some of the patients in the pilot panel, this is all of their potential comorbidities and factors going on. You can see it's pretty equally spread between things like CAD, CHF, COPD, and depression and diabetes. A fair number of those had falls risks and CKD, as well as other. Those other are factors that did not fall into those brackets. Anything else there, Dr. Kappelman?
Being a typical geriatric practice, most of the patients had many, if not all of these diagnoses in their panel. They're chronically ill patients, almost all of them with multiple diagnoses. That was part of the criteria for care management.
Yep, exactly. So in terms of the results, they were not honestly what we thought they would be. Part of this, I will just cut to the jump of why, is we had such a small sample size that we just really had a difficulty in patient match. As you can see there, the control patients, they're decently well balanced after a 1-to-2 match, but with that very few enrollment within the program, there was just a lack of statistical significance. But where we could do some matches, there were some differences. We did look at a pilot group versus a post-intervention relative to pre versus matched control group. Within the outcomes, many of them could not be tested, unfortunately, because we could not find a match to the baseline. However, when we looked at total cost, there was similarity at baseline. Within the pilot group, they had about a $386 and change higher cost with the post versus pre. So that actually is showing that they cost more after the intervention. But unfortunately, when we looked at p-value, it was 0.238, so not having statistical significance here. Now, when we looked at the post-only analysis, the group had a similar $380 higher cost than control, but again, that p-value was only equaling to about 0.2. So again, not statistically significant, but as we'll see here in a moment, thanks to Dr. Kappelman, anecdotally, we heard so many great things about this program that really warrants more study of this.
Yeah. One thing that might explain that, and I hate to explain away statistical data, I believe in it strongly, but at least a third of these patients had a new diagnosis that we were helping them manage. I'll tell you in a minute about a lady with new onset atrial fibrillation. And some others were patients that were new to my practice. Not that I'm that great, but it was a whole new transition for them. And I don't think they were cared for in as cost conscious a way prior to being a part of the practice. So.
And one testimonial from the patients you can see here, they said basically without this service, they would have most likely gone to the ER and been admitted. As you know, admission to an inpatient facility that is unnecessary, as well as any kind of readmission, can really rack up costs. And that's one thing that we really want to be mindful of, since we do have Dr. Kappelman in a value-based care arrangement in an ACO. A next testimonial here is from a care manager within the practice. Do you want to speak to this, Dr. Kappelman?
Well, y'all can read it, but yeah, she was an invaluable member of the team, and she did most of the referrals and took care of the paperwork for me to get these people enrolled in the study. She was an invaluable member and did a great job getting these folks there. But she also saw the benefits being the first line person, and she thought it was a great idea, and we appreciated her help doing it.
Yeah, and one thing that I would love to stress here as well is what Dr. Kappelman alluded to earlier, which is a team-based approach. I mean, literally everyone from the Aledade team, the Kappelman Medical Group, we were all invested in this program and trying to make sure that patients who would benefit from this were enrolled and that everyone was aware of what this program was. So if there was a call into the office, everyone knew how to handle that and make sure that it was elevated appropriately.
No, there's no doubt, like we said earlier, that we avoided many emergency room visits, some just for the very same day. We would work these people in instead and had to talk them out of calling 911. And thanks to the ability to transfer using the assets of Aledade, that helped us many times also. So there's no doubt that this saves some, not only emergency room visits, but hospitalizations.
And before I get to some of those results outside of this pilot, Dr. Kappelman, would you be willing to share some of, just some case studies within those patients and what was going on?
Yeah, absolutely. Like I mentioned, one of them was a lady that was not that old. She's 70 years old and not very medically sophisticated, but she did have new onset atrial fibrillation. And she, as you all know, that required initiating some new medicines to control her heart rate as well as anticoagulation that she quite simply didn't understand. And we were able to walk her through that without hospitalizing her, and her cardiologist, as well as our staff. She has not been hospitalized yet. She was chosen not to be cardioverted, and she's doing well on rate control and anticoagulation to this day. Another group was actually two older ladies who were good friends, and both of them were in the program. And unfortunately, they would try to one up at each other occasionally on how ill they were. And frequently that led to a visit to the office or even a contemplating calling 911. And the paramedic service would diffuse that situation several times. We had a gentleman who truly had end-stage COPD, and he was not hospitalized for over a year. This man was dependent on high flow oxygen, steroids. Amazing that he stayed out of hospital as long as he did. I think the paramedic service deserves a great deal of credit in doing that. And finally, we had a lady, a dear sweet lady who's 92 years old, who throughout his whole life cared for an autistic son who was sick, who's my age, a guy I grew up with, who's 60 years old. And she was able to stay in her home and continue to care for this, her child that she had cared for his entire life for another year, thanks to the benefits of this service. And none of these patients would have qualified for traditional home health care, certainly not for the period of time that they received the paramedic service. I think that was what made it so valuable to us, is we did not have to go through the hoops, find the diagnoses that would get them qualified for traditional home health care, which again would not have given them the personal service, the repeat visits by the same person. It was a tremendous asset to those patients.
Yeah, and that's one good thing to note as well, is the continuity of care. It was always the same paramedic. So when they were being visited, they were being seen by that same individual over and over. And so they really got used to seeing that person. As you can see here, one of the testimonials was it was nice to have someone come and check on them and talk, and they would miss having that person. So I really as well commend the efforts by the paramedic and making sure that they were defusing situations, elevating ones that warranted Dr. Kappelman's review, and just making sure that we were really privy to everything going on in that patient outside of the four walls of Kappelman Medical Group in the ACO.
The fact that they had another person to go to if they were anxious, if they were unsure of their situation, really helped, again, further their care and keep them out of the emergency room.
So in speaking about the actual program itself, this is outside of the study that was conducted by Aledade. There were results that were netted. As of July 1st, the program itself has cared for over 450 patients. Within that panel, they were able to look at hospital readmission rates of about 5.86%. When you compare that to the counties that those patients reside in, that's actually a CMS Medicare rate of 19%, so well below average on hospital readmission rates. So really doing a great job of keeping those patients out of unnecessary readmission. And then within the services, they did partner here with a local hospital and were able to embed the paramedic within their CHF clinic as extension of the clinic itself. And within that program expansion within the clinic, they were able to avoid expenses totaling about $150,000 in the first 12 months. So even though our findings with the low statistical sample and minimal significance, overall, when you look at what this program is able to do, sending a paramedic into the home, there are numerous ways in which this can benefit a practice, numerous ways in which it can benefit an accountable care organization or any individual trying to look at ways to engage their patient population in a good value-based manner. In terms of the overall findings of the service, would love to get your take, Dr. Kappelman, here on that first one about the full 360 of a patient.
We've talked a bit about, again, the importance of going in the home, assessing the patient's situation, their bedroom where they sat, the rugs on the floor, the nutrition in the refrigerator, the support. Frequently, these paramedics were there a long period of time, and the support that they would get from other family members, neighbors, all that was assessed in place. And anything that was unsafe was able to be dealt with through numerous resources that they had, and also identifying other resources that I had. So a lot of things that we would never have seen if they haven't been in that environment of their home.
And one great benefit, they were truly flexible with the changes going on. As you can imagine, when COVID hit in March, we wanted to ensure that we were doing those labs. Those patients were continually being seen, that telehealth, which was not utilized as frequently as today, was equipped with that paramedic so that if use was needed and warranted, we could go through with the facilitation of that. It also really dovetailed nicely with the work that we were doing for our accountable care organization and Aledade's work. We truly are trying to make sure that we're preventing unnecessary high cost, high utilization spend while ensuring a high degree of quality. That's really the crux of what value-based care medicine is looking at. And this really, again, just aligned beautifully in order to make sure that we were doing that work. Now, again, you heard quantitatively, it did not necessarily fit due to low sample size, but qualitatively, as shared by Dr. Kappelman, with those patient testimonials and stories, there was clear benefit of this program.
I think that you said it very well. There's clear benefit, and the fact, especially during the COVID crisis, that these people had a touchstone to go to that was inside their home, if not a phone call away, just one more person that they felt comfortable reaching out to, really made a difference in their general overall health as well as their mental health.
And as I stated, one of the services that was rendered was patient satisfaction. The paramedic program does this with all of their services rendered, and within that, conducting a Net Promoter Score, NPS. The result was actually ranked at an astonishing 95. And for anyone who knows NPS, 95 is very high. Additional feedback, as you saw in the testimonials, was given to both Aledade and Kappelman Medical Group, and it was always a positive experience of those that were enrolled. The additional ability to customize approach, once we were saying that we needed labs done, we were, wanting to extend our ride sharing opportunity for those folks who we deemed inappropriate to drive themselves in. The group was wonderful. I mean, they really were coming to bat at everything that we threw at them, and were a wonderful partner.
They would come in and suggest new interventions, new things they could do. Drawing labs and collecting urine samples, et cetera, was not part of the initial scope of services, but they volunteered that, and we provided them the supplies, and they jumped right in, and anything we asked of them, the paramedics would do, and they more often than not, they were suggesting something new that we certainly okayed and helped to the benefit of the patient.
So with all of that, Aledade took a look and said, this is really worth meriting more attention. We want to make sure that we put some resource investment into this and take it at a larger scale and have deeper market penetration. And so what we're looking at doing is having a fully funded Aledade approach to this and expanding it to more practices within our ACO. So that way we can have higher sample size and really test whether or not we did make some impact for statistical significance around cost, utilization, quality, and more. So there's more to come with this. In terms of that future study, you can see here on the left of our initial selection of what we were looking at within the pilot study, but we want to make sure that we double click more on expanding that selection. So we're going to look at things additionally around remote patient monitoring, as that's a new venture within what's allowed by CMS. Palliative care is a big component of what we try and do for our ACO work to begin with. End-of-life care is a very important factor. As many of you probably are aware, many patients spend the majority of their healthcare costs at the end of their life. And so by having appropriate palliative care and end-of-life discussions with those patients, we may be able to prevent some of that from happening when it's unnecessary. Dialysis support is another big one. And then the annual wellness visit for Medicare is something that we're looking at as well. How can we maybe produce part of the health risk assessment portion of that and then volley that over to Dr. Kappelman to either do via telehealth or in-office visit and really ramp up the optimization of something like an AWV visit.
Yeah, one of the big limitations, and some of the barriers have been removed, but the big limitation is that in-person assessment for the part of the AWV that we haven't been able to do. And I think this may be a way to crack that nut, again, with some of the relaxation and temporary or permanent of the requirements. We can still meet all the requirements with the paramedics' help.
Yeah, so even though we have gained regulatory pass-throughs right now with the pandemic, we want to make sure that we are still able to do some of those services. Even if the patient has a blood pressure cuff or a scale at home, having the paramedic bring those, make sure that they're calibrated, that really shows a lot more benefit to that type of visit. And then we can render it, in the same quality or high caliber that may be done in office. So that concludes our session today. Again, I'm Andrew Chang with Aledade, and if you would like, feel free to reach out to me. My email is on the screen.
And same goes for me, and we're happy to hang around and answer questions.
All right. Well, thank you everyone for joining us. There's been a significant number of questions that have already come in and been answered by our speakers. Give a little bit more time for questions to roll in. I just saw one from Susan Klein who asked, do you know if this is being done elsewhere, including other states where there may be licensure differences?
Hey, Chris, this is Andrew. So to answer Susan's question, we are working, I saw someone ask whether this was a program by a gentleman named Ken Peach, which it is. Ken is here in Central Florida with us and has been expanding this program around the state. He is looking at how we can do this elsewhere since there are paramedics everywhere across the country. So it's not something that is, honed in here. It could be done elsewhere, but right now through this community partnership that we did with Ken is just in Florida.
Excellent. Dr. Kappelman, anything to add to that?
Ken, this was Ken's idea that he presented it to us as well as the district, and the district jumped on it. And since I'm a prior chairman of the district, they came to me and had me as a test site. But we're trying to get it expanded through every primary care doctor in the whole district if they'll latch onto it.
Excellent. Andrew, you touched upon this briefly, but is there anything right now that you're looking forward toward the expansion of this program in 2021 that you didn't go over in the slides?
Yeah, I mean, for the most part, everything that was in there with the slides is what we're going to be looking at. We do want to expand this outside of just Kappelman Medical Group to our other ACO members to get a lot more density. And we do feel like that will also provide different social determinants of health with different populations. So we're actually looking forward to seeing what that brings and how we can potentially add in more services that may benefit the patients, but ultimately the practice and the community at large.
We had one question come in asking, what do you anticipate a safe paramedic to patient ratio to be? Can you talk a little bit about just the extent of how many paramedics you were using versus the providers in the clinic in this private program?
Yeah, so Ken had a ratio of about, I think it was somewhere around 15 to 20 patients on a roster per paramedic. He did fully employ those paramedics. They have a car, they go out, they have full electronics. And part of the ratio that we had to think about was whether they were a once a week visit, whether they were twice a week. And so they would flex patients in and out of that ratio depending upon that. The other factor is drive time. So with the grant, we were locked into a certain community area, but with their overall service, they were able to reach a pretty far network of patients. So that is another factor that they would have to consider as well that would impact that ratio.
They made no limits on the contacts or the ability of the paramedics to work with these patients. So some, as you can imagine, some were calling them daily and some they would see every 2 weeks. There was no limit. So it's hard to know what the ideal number is at this time. That number will grow with experience.
I think we had a number of questions during the session, and just now someone asked about the scope of what the paramedic was doing. What was the extent of the role? Obviously, you touched upon how if there needed to be a referral back to the clinic for doctor to deal with something via telehealth, you mentioned that. Anything else that you'd like to say about just the scope of what the paramedics can do? And many people had questions about the flexibility of using other roles, such as visiting nurses and others, in a model similar to this.
Well, I can't stress enough what I said earlier in the presentation about this anxiety relieving issue, that just having another point of contact that they felt very comfortable calling, how that impacted on their not choosing a higher level of care. This was a perfect program for the extreme worried well, if you will, even those with very stable chronic problems. A lot of these people were accessing higher levels of care very easily, with very little resistance on their own part, and that's where this really shone. In addition to getting these people and their families to understand their disease processes, their medications, and all the stuff that we all know takes visit after visit after visit and reinforcement. That's where this program really shone, and that's the kind of thing that you can't qualify a regular visiting nurse for. So it really has a great niche.
Yeah, and to answer Jennifer's question just around the paramedic, they did only service this program. They were fully employed by the community partner. So they were only providing services under the umbrella of this paramedicine program.
And then Joel just asked, what percentage of your practice is Medicare eligible or those enrolled in this program?
My practice, I'm a geriatrician, so my practice is about 40%, 50% Medicare. And almost all these patients were Medicare patients.
And then I want to come back to one question that was asked earlier that we want to follow up on. Do you think this type of program would receive pushback from the visiting nurses group or hospital emergency departments with respect to revenue loss? I don't want to lead your answer, but I have to imagine participation in ACO and having some skin in the game on these outcomes makes it an initiative for you guys without respect to some of those other groups.
Yeah, you're absolutely correct there. And one thing to note is this program is already being done with the hospitals in the area. They actually are wanting something like this. And they're doing it more on a disease state base. So they are looking at folks that have CHF, that have diabetes, that have renal dialysis, and they're honing in to make sure that they are actually sending this paramedic into their home, providing services and preventing readmissions, because they're also getting dinged on those readmissions. So they're wanting just the same as an ACO to prevent some of those things. Obviously, you're correct in that, it is a revenue conflict between what we're trying to do of keeping them out versus maybe a hospital. But I think we have a really good community basis here that we are all trying to work towards what's right for the patient. And so it's actually not really come up right now, but we'll see in the future when we expand this pilot.
And George just asked, is there a pending paper that will publish the results of this study?
Yeah, so Aledade is looking forward to expanding this and getting a lot more statistical significance so that we can do a white paper on this. We published many case studies on our website, which is aledade.com, and you can follow along there. And as we conclude the study, most likely in spring or summer of 2021, we hope to have that white paper out within the next probably 2 to 3 months after.
Excellent. I think that covers all the questions that have come in so far. I want to just put it to you guys again one last time. Any parting thoughts before we conclude the session today?
I'll let Dr. Kappelman go first.
This program has been so much fun because it's a service that you really want to be able to provide to the patients, the people that need it, and it's been something that's hard to come by. So that's what my parting comment is, that it's really made the joy of caring for patients that much easier to come by, because you're able to simply care for them and not worried about finding the right diagnosis or the right box to put them in so that something gets paid for. We actually did just have one last question come in directed to Dr. Kappelman. How do you deal with the intermittent nature and on-demand impact of communicating with the paramedic? We have real-time communication with them, that when they call, we answer. If it's not, we answer immediately. It's within minutes, because we treat these people, there are only two of them, we treat them as team members. So it's almost, especially in this virtual world, it's almost like they're here in the office and we just talk to them like they were right here. So it's they have a priority line to not actually, but figuratively to my nurse and myself, because we know that their questions are pertinent and helpful and are going to help our patients. So it's pretty much real time.
Yeah, and ultimately we also we partnered with a rideshare program. So if the paramedic was calling and the patient needed to come in for a same day appointment, we would supply that as well. So Dr. Kappelman and the group there, definitely elevated any of those calls coming in, because it could have been a patient that needs to come in right away for a service.
Excellent. Well, thank you both for this great presentation, and thank you for everyone for joining us today. Remember to visit the Solution Center to find partners that will address topics like this from today's session. Also, I just want to send a reminder, be sure to visit the trail map in the Virtual Convention Center to be entered to win big prizes today at 2:45. But again, thank you all for joining us. This has been a great session, and we look forward to rounding out the education on this last day of the Medical Practice Excellence Conference. Thank you all.
Thank you.
Thanks for having us.